So welcome to the Birmingham Medical News Doctor Talk podcast. I'm Steve Spencer, the founder of the Birmingham Medical News, and this podcast is a joint venture between the Birmingham Medical News. It's a newspaper for doctors, nurses, healthcare executives, and providers we've been publishing in Birmingham now for 20 years. About 20,000 people a month get the paper, either in hard copy or digital version. And our partner in this is Kassouf & Company. We actually do this at their studios. Kassouf & Company is an accounting firm in Birmingham that goes back almost 100 years. In addition to, accounting for individuals and businesses, Kassouf & Company has a wealth management arm, and our tie-in, I guess, with Kassouf is they've got a great healthcare advisory department. And so we really thank Kassouf for helping us with this. And the sponsor for today's podcast is Brightmark Health. Now, that is actually Dr. Joseph Wu. He founded Brightmark Health because he had grown really frustrated with, I guess you'd have to almost call it corporate healthcare.
Too often, healthcare and the large practices focus too much on profits and not enough on patients. Primary care doctors in these practices are overwhelmed with too much to do, leaving them with only a few minutes with each patient. He founded Brightmark Health with a mission to take primary care back from the massive corporate entities running medicine and focus on you, hoping to return to meaningful doctor-patient relationships where active listening is at the heart of every interaction. They empower you to take better care of your health, which is how it should be. As your concierge doctors in Birmingham, they believe that your health is personal and should be treated that way. They focus on putting the patient in control of their well-being, offering a transparent and straightforward approach to primary care, no insurance complications, no hidden fees, just quality care that puts you first. So we would like to thank Dr. Joseph Wu and Brightmark Health for sponsoring today's podcast.
Okay, so our guest today is Dr. Jan Rowe. She is a doctorate of occupational therapy, and she is in charge of a really unique clinic. It's the Tourette Syndrome Clinic at Children's of Alabama, and it's one of only 23 in the world. Anyway, we were talking earlier, and I'm just going to, Dr. Rowe, you please give us your background because it's pretty interesting.
Okay. Thank you, Steve.
Yeah.
So I am an occupational therapist. I was on faculty at UAB for 25 years. And in 2009, learned about a new treatment approach, a behavioral program for children and adults with tic disorders and Tourette syndrome. Colleague and good friend, Dr. Leon Durr, put me on to this particular kind of therapy that was being offered through the Tourette Association of America. I got trained in that therapy, which is called Comprehensive Behavioral Intervention for Tics, or CBIT.
Okay.
And then in 2010, started the first clinic run by an occupational therapist. So I was the first occupational therapist in the country to actually develop and run a CBIT clinic. Mm-hmm. I retired then from UAB in 2012 and took the clinic to Children's of Alabama. Mm-hmm. So I've been at Children's 2 days a week doing the clinic since 2013 now.
Mm-hmm. And you're also telling me that the clinic, you send people from all over. I think you said international. Tell me the places people are coming from.
So we were one of the first, we still are really the only center of excellence in this part of the country. There is a center of excellence in Nashville, but for the first many years that we were doing the program, we were sort of the only people providing CBIT in the Southeast.
Okay.
So we had people coming to us from, of course, all of the border states, but then we also got some international patients that came in the summer. Okay. So we've had patients from, Indonesia and Turkey and Japan. Mm-hmm. So it's been one of those fun experiences that, people find out about you and, are willing to travel to come and get this therapy. And even with the 23 centers of excellence now that are known throughout the country, CBIT is still a very difficult thing to find for your child or for you as a person living with tics or Tourette. It's we still don't have enough people certified to provide this therapy.
Okay.
So it's, when people find out about a service and they can actually get in within a reasonable amount of time, they're absolutely willing to travel to get their child that therapy or they themselves the therapy.
And what amazes me, and again, I mentioned this earlier, is just that you're there. I mean, it's crazy the things that are in Birmingham, especially related to UAB, children's, et cetera, that are remarkable that we don't even know about. I mean, I was amazed that you were actually the first in the U.S. to do this therapy. You're getting people from all over. Well, anyway, though, to get started, explain to me, what is a tic?
Yeah. So tics are non-rhythmic movements or sounds that occur as a result of the brain sending basic signals to a person. They're usually preceded by what we call a premonitory urge. So it's something that you feel or you sense. It can be something very specific, like I feel like I have pressure in my throat and then I have to, do a throat clear, or I have to cough to get rid of that. And for most people, in their brains, the signals don't actually get through. You can think of your brain as kind of having like goalies or gatekeepers, and those gatekeepers keep those signals for passing through so that you don't have to act on every signal that you get. But for people who have tics and Tourette, those goalies and gatekeepers don't do a really good job. And so the signal passes through. The urge that they feel or they sense is so strong that they can't not do it. So whatever that urge or that sensation is, they have to act on that. So they do the tic, which could be, a shoulder shrug or a throat clear or eye blinking or a head jerk. And then they get a certain amount of relief from having done that tic. During the period where they do the tic and the relief occurs, that happens because of a dopamine rush. And so the dopamine is that feel-good drug in our brain that allows us to get some relief, and that's what then continues the cycle.
So you're saying that they get a dopamine rush after they
tic.
Okay.
Yeah. So that's what keeps the cycle going. And that's why you tend to see tics when they happen in bouts. And it could be 10 seconds or it could be a minute and a half where the person is ticking. And then the tic stops and they might not tic again for 3 minutes or 3 hours or maybe 3 days. Tics vary. They come and they go. And that's just the natural part of tics.
You mentioned the time that it varies. Are there people who have tics very rarely, like every few months, or is it? And what's the really bad case of how often?
Yeah. So it probably would. I mean, some people do have such a mild version of a tic disorder or Tourette syndrome, and we can talk about what the difference is there.
Okay.
That they might not. They probably are ticking daily or every couple of days, but it might not rise to the occasion where they are actually aware of that tic, or it doesn't cause them any distress, right? Okay. So it's not getting in the way of anything. They're not, they're not being socially ostracized. They're not being bullied. They're not being, made fun of. It's not interfering with their daily life, but they're probably ticking daily. It just may be so mild that most people, especially if you didn't, realize what a tic is, you probably wouldn't recognize it as a tic.
And I'm getting a little off our topic of questions, but one thing you mentioned there was kids getting bullied, and I just thought about that. This is going to be horrible.
Yeah.
Is it?
It happens a lot, unfortunately. Kids can be just so mean. So that's one of the reasons that we like to get kids started in this therapy, earlier than later, if it's causing them any distress at all. Because we know that if they have some kind of distress associated with their tics, and when I say distress, I mean it could be anything from this tic is actually causing me pain, like it's a neck tic and I get, Charlie horses in my neck muscles, or it could be that I, throat clear so much through the day that I have a sore throat. Okay. So it could be actual pain or discomfort that they're feeling, but it might just be that, I'm spending so much time thinking about my tics that I can't pay attention to other things. And I just don't want to have to deal with this anymore.
And so you go ahead. I'm sorry.
So for that reason, when we have a little bit of distress registered by the child, they are the perfect candidate for the CBIT therapy because they have to, we teach them to use a strategy or a technique prior to the tic happening. And for them to remember to do that, a little bit of distress is helpful because they're going to be motivated to use the therapy. They're going to, follow through with it. It's not just, come to see me once a week and magic happens. They have to be willing to use the strategies on a daily basis.
And one thing, before we get to the therapy, tell me what are the types of tic disorders? I assume there's...
Yeah, so you can have both motor and vocal tics, or one or the other, okay? And I guess the best way to start is differentiating what a tic disorder is, and that's like the large umbrella that all of the tic disorders fall under, including Tourette syndrome. So for a person to be diagnosed with Tourette syndrome, they have to have had at least 2 motor or physical tics and 1 vocal or sound tic over the course of a year, be less than 18 years of age, not have had any kind of head trauma or, adverse reaction from medications. And they would wind up with a diagnosis of Tourette syndrome. So Tourette does not speak to the intensity or severity of a tic disorder. It just qualifies the kind of tics a person is having. They have both motor and vocal, and they've had them longer than a year. And they're less than 18 years of age. So it doesn't have to be severe. You don't even have to have certain kinds of tics. Some people, unfortunately, have been told that if they don't have what's called coprolalia, or the cussing tic, saying rude, obnoxious things or actually obscene things, that they don't have Tourette syndrome. And that's just not true.
Okay.
Coprolalia is just a vocal tic. It's like any other vocal tic. Yes, the consequences of that vocal tic are obviously much higher and stronger than having, say, a throat clearing tic, but it's still just a vocal tic. So that falls under tic disorder. And then you can also have what are called transient tics. And those are very typical in young children, 2, 3, 4 years of age, where parents might see them kind of do like a little bunny nose scrunch, or maybe they do like a wink. And about the time a parent sort of figures out like, hey, they're doing something, like, what are they doing with their mouth? It stops, it changes, and they do something else. If it's a transient tic, it's usually one or the other kind. It's a motor or vocal tic. It's not both. And they usually resolve on their own early in childhood.
So I understand you're right. Everyone who has tics does not necessarily have what we classify as Tourette syndrome. What percentage of people with tics would be considered Tourette syndrome?
Yeah, so there's actually some broader thinking now that probably every tic disorder could be classified as Tourette syndrome, but I guess there are several camps on this. So at this point, the DSM-5, which is what people the physicians go by in terms of diagnoses, the criteria is still spelled out as I said. 1 in 5 children, school-age children, have tics. 1 in 100 people have Tourette syndrome. So it's a very common disorder. Very common, yeah. I mean, if you go to a school play and just watch kids up on stage, singing or play, doing their part in the play, you'll see tics all around.
I've totally seen that. And I just assumed, because my kids years ago went into, school plays and things like that, and, choir things. And I just assumed that it was just a kid who was sort of tired of standing.
Yeah.
Or they were just kind of.
Yeah. Or nervous. Yeah. And anxiety is a big trigger for tics. If you get uncomfortable about something, if you're stressed, both good and bad stress. So, like only 2 more days till Christmas break, or, 2 more days and I have that big math test. Either level of stress can really trigger your tics.
And so if 1 out of 5 kids have tics, I assume that an awful lot of those don't last their life, because I would be shocked to find out that 1 out of 5 people, adults, have tics.
Yeah. So tics, like I said, tics are pretty common. A lot of tics do resolve in childhood. But again, there's some thinking that tics really never go away. They just become very mild, and the person your brain habituates to the feeling of, that urge that we were talking about. and you don't necessarily have to act on it every time.
Okay.
Now, put that person in a pressure cooker, like they're getting married, or they just got divorced, or they're going for their driving test. They just signed for a new house, signed their life away on a mortgage. Those real stressful kinds of events, you might see those tics reemerge. And, people around them would say, oh my gosh, I haven't seen them do that in 10 years.
And let me ask you, you say the brain habituates, and that totally makes sense. You mentioned earlier, and I don't know the correct physiological term, but you mentioned that there's a gate in our brain, I guess, that would close that. When some of them go away, could it possibly be that sort of gets fixed or ameliorated?
Well, so, it's like anything else. If you put, a rock in your shoe and you were walking around with that rock in your shoe, the first several hours, you're going to be very aware of that, right? But at some point, you become so used to it and your brain has been, adapted to it and habituated to it that you kind of have to stop and wonder, like, did I take that rock out? Is it still in my shoe? It's kind of the same thing. So we get used to the premonitory urge. And like I said, if you're not feeling a lot of stress, if you're not feeling some kind of expectation, like in a quiet room, you typically have vocal tics, and now you're put in a quiet room and the expectation is everybody's quiet. Well, that's when your brain is yelling at you to do the vocal tic, like do that throat clearing, or say that word or whatever. So when you know the social norms and you're trying to abide by those, that's when it becomes really difficult and you become acutely aware of that urge. And the only way to get rid of it, you think, is to do the tic.
Okay.
So now we do know from functional MRIs that when people are going through CBIT, which we'll talk about, that actual changes in the brain do happen. And people do have some success with basically retraining the brain. In the way that it responds to those signals and urges.
Well, let me ask you this, before we get to CBIT, before we start talking, you and I talked about some of the previous treatments with pharmaceuticals.
Yes.
Tell me a little about that, and then let's go into your therapies that are different.
So for years and years, really before probably 2006, 2007, the only approach to tics and Tourette was pharmaceutical, if there was going to be any intervention at all. And that was, everything from old school antipsychotic medications to anxiety meds. And there are still a lot of, people who do prescribe medications for tics and Tourette, physicians who do. I'm fortunate to work with a movement disorders group here at Children's in UAB that don't prescribe meds for tics and Tourette. We've had so much success with our behavioral program that, and the literature also bears this out, that the behavioral program is as effective, if not more effective, than medications. Unfortunately, the biggest drawback and side effect of the medications, if they work at all, which most of them don't for tics, but if they have any benefit at all, they also tend to make people gain weight, which is never a positive for people, but especially when you're talking about kids. A 10, 15-pound weight gain in a child, that's huge. And, we were talking earlier, too, about just kids are mean.
Right.
And, you're in class with someone who's just constantly putting on weight, and that person, unfortunately, becomes a target for a whole nother reason.
Yeah.
So, thank goodness this behavioral therapy is now available, the CBIT. And like I said, it's highly successful. And that's not just in our clinic. It's routinely, it's a highly evidence-based therapy. It's very effective both in person as well as telehealth, and we do our share of telehealth visits as well, which has been really nice. That really just blew up during COVID, of course. It was the only way for people to receive the therapy. And lots of studies have been done since that time showing that it's just as effective as in person.
Well, tell us about the therapy.
Yeah. So it's basically, it's a weekly therapy where people come in, we talk to them about their tics. We do a lot of education about the difference in, tic disorders, if you just have movement tics versus vocal tics, or if you actually do have a Tourette syndrome diagnosis. People who have Tourette also tend to have comorbid conditions. In fact, 87% of those people with Tourette diagnosis have comorbid conditions like ADHD, OCD, anxiety. That's kind of the trifecta. And so those conditions can and probably will cause them more difficulty down the road than their tics will, especially once they, learn the strategies that we teach them in CBIT. So it's a weekly therapy. We teach them basically just we call it a competing response, where we do something that's opposite, if you will, of the tic. We don't give out fidgets. We don't ask them to, try to distract themselves. We just say, if you have a shoulder shrug where you're basically, pulling your shoulder up towards your ear, then we're going to do the opposite. When you feel that shoulder shrug about to happen, or when you notice that you're actually doing it, all I want you to do is push your shoulder down and hold it. Okay. So it's going to be something that is undetected by someone else. It's going to be something that they can do anywhere, anytime. Like I said, we don't, they don't have to remember to bring their fidgets with them or whatever. They're using their own body to create this competing response. And it also is something that they can do for up to a minute or longer until the feeling to do the tic stops. And for people who have tics, when your tic is done. It just feels like in your brain, it just feels like, okay, I'm good.
Okay.
So they don't have to watch a clock. They don't have to count. They just hold that competing response until the tic stops.
Okay.
Another example would be like blinking. Blinking is a very common tic. If it's fast, repetitive blinking or hard squinting kind of blink, then just casting your eyes downward and away from you. So for instance, if you're sitting at a table, like an arm distance away from you, looking at your fingertips, and then you don't always have to extend your arm like that, just the first time to kind of get an idea of the distance. Or if you're standing or walking just, 4 or 5 feet in front of you on the ground, casting your eyes down like that really is a very relaxed position for your eyes. It also allows the upper lid to close a little bit over your eye, so it creates a little bit of lubrication on the eye. And people will find that the blinking or the hard squint will stop when they do that. And they use this throughout the day, every day, in all situations, at school, at home, at Walmart, at the restaurant. And again, their brain habituates to the urge that they're feeling. And within 5 to 7 days, the tic stops. And we move on to a new tic.
I'll be darned. Okay.
Yeah. So we work on 1 tic a week.
Okay.
And the original protocol that was designed by psychiatrists and psychologists and that I was trained under basically said this was an 8 to 10 week program. And then you could have, up to monthly booster sessions for about 3 months.
Okay.
I last year wrote a manual for occupational therapists because I teach OTs how to do this work. So I published the first CBIT OT manual, and our manual is a little bit different from that original protocol in that this is a very fluid situation, and every patient is different. So I might see a patient for 3 or 4 weeks and then maybe check out with them a month later just to make sure that they're still good, and they're done. And I don't see them again.
Okay.
Or if I do see them again, it might be, 1 or 2 times just to kind of refresh them on the strategies, reminding them how to come up with the strategies. Maybe something significant in their life has changed. Maybe parents got a divorce or they had to move schools or something, created a lot of stress. Their tics resurged and, they need to come back for some tune-ups. But typically when they're done with the program, that's it. We don't see them.
Okay.
Now, I see children as young as 4. So those children, we basically deal with the tic that is causing them distress in the moment. And then I might see them many other times throughout their development, simply because they're getting older. The tics are either not bothering them at all and I don't see them, or they get other tics and those tics now are bothering them and they want to come and do the whole program.
Okay.
For us, the whole program looks more like 4 to 6 sessions now.
Okay. Okay.
Yeah.
One thing you said the tics are gone. I assumed that they still have them, but they're just holding them off, like the shoulder you mentioned?
No, they actually just don't even feel like they need to do it anymore. Do you? Well, again, it's the brain habituating to that particular urge and getting used to the fact that I don't have to act on that anymore. And then
So the urge doesn't necessarily go away. Is that correct?
the urge to some people never goes away. But you just don't have to, it's not as acute. You don't feel it as much.
It's almost like if you have an itch and you just don't scratch it.
Exactly.
Okay.
Yeah. But then some itches, especially if you're in a really tense situation, you're very aware of that itch and you have to scratch it. Right? So, and that's more the current thinking is that if you throw that person into the pressure cooker and, turn up the heat a bit, they're probably, you're going to see some ticks out of that person, even if they are reporting they haven't ticked in years.
Mm-hmm. Okay. And what about what have you found that the center does for parents?
That's a great question because when kids come to see us and their parents, sometimes they're newly diagnosed, and when people hear the words Tourette syndrome, it's like their world has stopped because the first thing people think is, oh my God, my kid's going to start cussing and, saying all kinds of.
I think there's probably a lot of misinformation because that's all I thought it was.
Right.
Yeah.
And, we have the media to thank for that because that's what gets, that the sound bites are what, our world lives by. So we do a lot of education for parents, for children, for schools. I work very closely with schools. I go to schools, sit in classes, work with teachers, and of course parents. And we provide a lot of resources to our parents. Because we are a center of excellence, we have materials of our own, but we also have all of the materials from the Tourette Association. So we send them out with a packet that's probably 4 to 5 inches thick of information. As well as providing books for the children, books for the parents to read. We want them to be as informed as possible and not by Googling. We want them to have the most evidence-based information and the stuff that we know is
because Lord only knows if you Google what kind of wrong information you get. But it sounds like it's really thorough. I mean, when you add in all the information, including books.
Yeah, it is very thorough. And we know it's a journey. So, we continue to, I think I have to apologize a lot of times to parents because I'm sitting there with a 6-year-old and them, and I'm talking to them about now when they go for their driver's tests and when they, graduate high school and, I'm advancing their child before their eyes. Yeah. But I want them to understand that this is going to be something, CBIT is not a cure. It's a management tool, right? And we give them all the tools to be able to manage their TUTs, and they're very successful. People with tics and Tourette have average to above average intelligence. I mean, there's no reason for parents or anyone else to think that they're not going to do well. Right. Now, all of that said, there are people, it's a small percentage of people, but there are people who are very involved with their tics, really cannot do anything else but tick all day long.
But can these same people, can those folks get some pretty good help with behavioral therapy?
So CBIT is obviously the frontline therapy now. Everybody signs on to that as being the thing that you do first, not medication, but CBIT. There's, like I said, there are still a lot of physicians who prescribe meds along with CBIT, but CBIT is considered to be the frontline therapy. For people who have what we refer to basically as intractable tics, they will probably try CBIT and it might help some, but it's not. They probably are not going to get the kind of result. Well, we know they're not going to get the results that, the average person that I see or that most centers of excellence see. So there is deep brain stimulation available, and it's been successful. It is, of course, the last resort because it's brain surgery. And there are certain centers, the closest one to us really for tics and Tourette is at University of Florida. And they've had great success. There are people working in this with DBS internationally. They have a brain mapping system that they use, and there's a data base for that. So, insurance is not consistently paying for DBS, which is also difficult because it's, of course, just insanely expensive. And then people have to go through a lot of, pre-therapy and counseling and evaluations and that sort of thing to see if they're going to be a good fit.
Right. Yeah. And is that, you said brain stimulation, are they putting in a little
electrodes?
Yeah, gotcha. Okay.
Yeah.
Well, I'm glad to know in those cases, at least there's something.
Yes.
Yeah.
Yes. But those people will all have at least tried CBIT. And like I said, even if they get a 10 or 15% success out of CBIT, that's more than they had, right? But it's not like the, 85 to 95% success rate that we're used to seeing. Yeah. I mean, they're just, there are very few things in life that you get that kind of results with. So if the child and family are willing, they absolutely will get success.
Yeah, that's fantastic. How are patients referred to you?
Well, for the first many years, it was Dr. Durr referred all my patients to me until kind of word caught, and he did such a great job of communicating to other neurologists and pediatricians and physicians that, hey guys, this is the way to go.
Okay.
And now, of course, like I said, it's a frontline therapy. So we get referrals from, of course, all over pediatricians and internists, general practitioners, neurologists from, all over the state and out of state. So we're well known now, but in the beginning, it was definitely, Dr. Durr and me. We were the two-person show.
Well, that sounds great. Anything you'd like to add? Anything we haven't touched on?
I think the only other thing is if people are interested in, having their child seen through the center, they certainly can contact me. Our website is on the children's website, www.childrensal.org/CBIT. Because we're a center of excellence, we also have an adult program, and that adult program is for people 21 years and older. It is also implemented by occupational therapists, and they are housed in the School of Occupational Therapy, School of Health Professions at UAB.
So those are people who just didn't get it when they...
Right. Yeah, they did, or it just wasn't available because, like I said, before 2010, this type of therapy just didn't exist. So if they were diagnosed late in life, or maybe, they didn't necessarily feel like their tics impacted them, in their 20s or during college or whatever, but now, they're young adults and they're in their work lives and their, home lives, and they would like to try it, then, they obviously can do that. And just like in the children's program, the therapy for adults is provided both in person and or telehealth. So, if people can't come to us weekly, then we can do telehealth sessions.
Okay, sounds great. Yeah, and I'm sure the telehealth is great for people in far parts of the country. Even you said you had some folks from overseas.
Yeah, exactly. And even just, 4.5, 5 hours, we have people from Mobile and, or, Gunnersville or, and weekly is daunting, with people's busy lives. So if we can make that easier for them and make it more accessible to them, then, we want to try to do that as often as we can. Insurances during COVID, of course, we're paying that completely. And now we've been working with Blue Cross Blue Shield to reinstate telehealth payments for CBIT. United Healthcare still pays for telehealth for CBIT and OT in general. And then also TRICARE pays for that.
Well, we appreciate your time.
Thank you.
I learned a lot. I didn't know you were here. I didn't know how rare it was. I didn't know how actually pervasive tics were.
Yeah.
I would have never guessed it's 1 out of 5.
Yeah.
So,
which also helps kids, I think, when they come in, because they think they're the only person in their school or the only person on their baseball team, or so it helps them to know. We basically talk about the famous people who have tic. Tim Howard, who was the men's national U.S. soccer team goalie, who's just a great guy. He has Tourette syndrome and ADHD. There's a book out called The Keeper, and that's one of the books that we provide in our clinic to kids to keep. It's a great book. It's basically a biography about him growing up with tics and ADHD. His life is, becoming the great athlete and guy that he is. He also has a leadership academy that's through the New Jersey Tourette Syndrome Support Group.
Okay.
He does a lot with them. He's a great advocate. I'm blanking right now. There's a baseball player whose name I can't remember who has Tourette syndrome. There are actors and just all kinds of people. And then, of course, we try to match families up with other families to allow their kids to know each other.
Well, thanks a lot. It's been great.
Thank you for having me.
Absolutely.
I appreciate the opportunity. I could talk about this all day, so thank you.
Well, I could listen quite a lot.
Thank you for listening. to today's episode of the Ask the Doctor podcast, brought to you by the Birmingham Medical News and Kassouf & Company. Please make sure to like and subscribe, and make sure to tune in for our next installment. I'm Steve Spencer, and wish you and your loved ones a healthy journey until we see each other again.